And now let me focus about upfront treatment in the transplant candidate patients. Until now, it was clear that the best option was a triplet. VTD, bortezomib thalidomide, dexamethasone, or VRD, bortezomib lenalidomide, dexamethasone, or KRD are nowadays the standards. We have now a very important randomized study conducted by Philippe Moreau, in which they have compared the standard VTD versus the same standard but adding a monoclonal antibody, in this case, daratumumab. And this study showed that the primary endpoint, that was stringent complete response, was achieved, but what is more important, the minimal residual disease status was 63% versus 43% in favor of VTD, and this explains the PFS benefit. The hazard ratio for PFS was 0.47, and 93% versus 85% of the patients were progression-free at 18 months. The overall survival is still immature, but again, the hazard ratio is around 0.45. In other words, clear benefit by adding a monoclonal antibody. It's not the same, the benefit in the high risk, and this is why we need something else in the high risk. The data on VRD versus VRD plus data is more immature, but again, we have already information on the minimal residual disease. The minimal residual disease, 51% versus 20%, double the minimal residual disease. The stringent CR is 42 versus 32. And again, benefit in PFS, although I would confess that this data is still mature, and I think we need to wait. Okay, having all this data, do we need autologous transplant? Or can we escape autologous transplant by using these quadruplets? We don't know yet, because this study has not yet been performed. But we know, if you have not a monoclonal antibody, what is the outcome of using early versus late transplant with an induction based on schemes such as VRD or VCD. And there are several studies, the French study, the EMN study, that show in all of them that early transplant is associated with a benefit in progression-free survival. The 4-year PFS in the pooled analysis of the European Myeloma Network, 4-year PFS is 44% versus 25%. Very clear. Something similar applied in the IFM Dana-Farber study, that all of them speak in favor of early transplant, at least before using a monoclonal antibody. And in fact, we have also the data from the Forte study with the KRD plus autologous transplant versus KRD, more intense KRD, 12 cycles without the autologous transplant. The initial results indicate that both schemes, KRD plus autologous versus KRD without autologous, but supplemented with additional KRD, 4 additional cycles of KRD, can be equivalent in terms of CR, in terms of minimal residual disease. But if you look in the high-risk patients, and if you look to maintain, to sustain MRD at 1 year, the figures are in favor of the early transplant. 90% versus 72% of patients remain MRD negative at 1 year. 1 or 2 transplant. I will favor 2 transplant if the patient is high risk. In a standard risk, I will continue with only 1 transplant. Therefore, what will be my preferred option for treatment of a standard risk patient? I will use an induction, if possible, with a quadruplet, proteasome inhibitor plus IMiD plus a monoclonal antibody, autologous transplant. If the patient is MRD negative, I will go to maintenance directly. If remain MRD positive, I will do a consolidation, probably with a different scheme. But I understand that this will be challenged by regimes such as a monoclonal antibody plus a triplet with VRD or KRD, whatever it is used. We will see in the future.